everyone, this is Amrit and I'd like to welcome you to Ask Pro Ed. Warfarin is the topic of this video, and before I dive deeper into that, please keep in mind that this video is for educational purposes only, and please never practice medical skills without the proper credentials. Okay, so I'm super excited about this video because it's called Warfarin for Dummies. So hopefully I can give you like a lot of information about the drug called warfarin. So warfarin is an anticoagulant that acts via the inhibition of normal vitamin K cycle. It's used for both the treatment and prevention of venous and arterial thromboembolic disease. Did you know that for over 60 years, warfarin was the king of the show? It was the primary oral anticoagulant agent until, of course, like the recent introduction of the NOACs, which are the medications like apixaban, rivaroxaban, dabigatran, etc. The NOACs are now generally the preferred oral anticoagulant, but unlike warfarin, they have no reversal agent. So this is like a major drawback. Therefore, warfarin still remains the first choice for patients with things like valvular heart disease or significant renal impairment, or patients that have intolerance to the NOACs. Warfarin has a very narrow therapeutic range, and dose must be carefully tailored to regular INR testing. Warfarin comes in tablet form and it is consumed orally. It comes in 1 milligram, 2 milligram, 3 milligram, and 5 milligram tablets. These tablets are color coded to help assist like patients in identifying the dose of the tablets in order to take the correct amount. It's completely absorbed from the gut with bioavailability of 100%. Warfarin is mostly entirely metabolized in the liver. There is very little renal excretion of warfarin, and so no dose adjustment is required in renal impairment patients. Treatment with warfarin should be guided by 3 factors. Number 1, presence or absence of active bleeding. Number 2, INR results. And number 3, risk of further bleeding of the patient. Did you know that there are 3 specific reversal agents for warfarin? And they are, number 1, prothrombin X, which has a rapid effect. Number 2, FFP, which also has a rapid effect. And number 3, vitamin K, which has a delayed effect. There are a few contraindications of warfarin, such as patients that are actively bleeding or patients who are at like a high risk from bleeding, so need to be used with caution. High risk factors for bleeding, well, you can check out the video I've done on the HAS-BLED or the bleeding assessment. There's a proper video, so go check it out if you've not already done that. And high risk factors to consider include like hypertension, so uncontrolled hypertension with a systolic of more than 160, abnormal renal function or dialysis, abnormal liver function like a patient with cirrhosis, or deranged LFTs. High risk is also someone with stroke or bleeding or INR, which is unstable or high, somebody who's elderly, somebody on drugs or on alcohol use or medications that predispose to bleeding. And last thing, thrombocytopenia. Warfarin is contraindicated in pregnancy. It is a category D drug. This category of drugs which have caused, are suspected to have caused, or may be expected to cause an increased incidence of human fetal malformations or like irreversible damage. So warfarin is considered safe to use in breastfeeding but not in pregnancy. It's also a no-go in spinal injection or puncture. In patients undergoing surgery, the risk of them bleeding during surgery increases with the INR. So keep that in mind. In elective surgical cases of like low risk significant bleeding, like say cataract surgery or minor dental surgery or dermatological procedures, it's fairly safe to continue warfarin as long as like the INR is less than 2.5 in people at high risk of VTE. For situations of elective surgery with, say, moderate to high risk bleeding, if appropriate, stop warfarin 4 to 5 days before surgery to allow the INR to drop to less than 1.5. If the patient is at high risk of thromboembolism, consider using bridging heparin or low molecular weight heparin, or continue warfarin and then give vitamin K the night before the surgery. And in Australia, we always freely seek advice from other teams like hematology. So you can always seek specialist advice if you're unsure. In cases with urgent surgery, you can seek hematology advice, especially if you're considering using vitamin K or prothrombin complex, or reverse anticoagulation is not possible, or if large doses of vitamin K are used, it can be difficult to reestablish anticoagulation. Warfarin can usually be restarted on the night of surgery at the previous maintenance dose. The onset of action of warfarin is around 36 to 72 hours, and the duration of action of warfarin is about 48 to 96 hours. And whenever initiating warfarin therapy, consider the use of a warning bracelet. And protocols vary between hospitals, and the guidelines should be followed where available. In general terms, a loading dose of 5 milligrams orally is given. Lower doses are recommended for elderly and or debilitated patients and patients with increased sensitivity. Whilst awaiting a therapeutic INR, more immediately acting bridging enoxaparin or heparin is used. Warfarin is commenced at the same time with enoxaparin or heparin therapy. So say 5 milligrams is given once daily for 2 days. Then the dose is adjusted according to the INR. Usually the maintenance dose is in the range of 1 to 10 milligrams once daily and must be taken at the same time each day. Please note that the full effect of a dose change will not be seen for 2 to 3 days. Patients provided with warfarin treatment should be advised to maintain an INR level diary or something similar in order to keep track of their daily dosing. Patients should consider using a medical warning bracelet or a necklace to alert people that they are on warfarin. Always remember that warfarin dose is adjusted according to the INR value. The INR is measured frequently, so in the beginning daily or second daily at the start of the therapy, and less frequently, like up to monthly during stable chronic therapy. Speaking about the recommended therapeutic ranges for INR. If it's prophylaxis of DVT, then the recommended INR is 2 to 2.5. If it's treatment of DVT, PE, or AF, recommended INR is between the range of 2 to 3. If it is a recurrent DVT and PE, or arterial disease including myocardial infarction, arterial grafts, or cardiac prosthetic valves, the recommended INR is 3 to 4.5. Foods that are high in vitamin K can reduce the effectiveness of warfarin, and common vegetables that contain moderate to high levels of vitamin K include vegetables like asparagus, kale, broccoli, lettuce, Brussels sprouts, parsley, cabbage, silver beet. So you can give that advice as well. And patients should also avoid drinking large amounts of cranberry juice, as this may increase the effects of warfarin. Okay, so I hope this was useful information for you and you got a good baseline information on warfarin. If you have any questions specifically, feel free to leave them down in the comments, or feel free to directly message me on the Facebook page. Don't forget to hit the like and subscribe. Until next time, take care.